And then it's up to you to go about and follow that path and learn it. So I'm going to quickly talk about bone and joint disorders in the diabetic foot, but there's no way in 15, 20 minutes I could possibly give you a detailed review of this. So I'm going to introduce this to you, and hopefully it'll make you more aware of some things you may not think about, and then go about learning about the subject, because as they say, your eyes only see what your mind knows. So there are certain bone and joint disorders that we see that are more common in our diabetic patients. There are diseases that are more common in the diabetic, disorders more common with renal failure, disorders more common as we have aging, disorders more common in obese patients. And here's an example of some of them. We all know about Charcot's joint disease and osteomyelitis. Osteoarthritis occurs more commonly in patients that have diabetes, particularly the ones we're seeing who are older type 2s. Hyperuricemia and gouty arthritis is much more common in a diabetic patient, presents differently in the older patient. Hydroxyapatite deposition disease, something you don't think about too much, but it's there. Diffuse idiopathic skeletal hyperostosis, calcium pyrophosphate deposition disease, limited joint mobility, so-called chiroarthropathy. All of these things I've listed here occur with increased frequency in the diabetic patient, but tend not to be diagnosed as much, in part because the patients aren't complaining of pain because of their concurrent neuropathy. Similarly, our diabetic patients have a higher risk of osteoporosis, osteomalacia. Our renal patients, which we're seeing more and more of, as you know, have secondary hyperparathyroid disease with fractures and avulsion fractures, problems such as that. Anyone who treats diabetic patients knows they have increased fracture liability and delayed fracture healing. This last week, I did 2 ankle fractures on older diabetic patients, and I looked at the residents. I say, you understand what a liability this is? Do you have any idea this patient's going to take forever to heal? They take twice as long. They need twice as much hardware. You need twice as many x-rays, twice as many office visits. You're not going to get paid much for any of this, and they're high-risk patients. And we have a whole subset of literature devoted just to fracture management in the diabetic patient. They have vitamin D deficiency in part because of their age, and in part because, for example, they're kidney disease, because your vitamin D is hydroxylated at the one position at your kidney, and if you have declining renal mass and declining renal function, you have declining vitamin D, and if you have declining vitamin D, you have declining calcium. You can't live without calcium. You need it for everything. Your body regulates it in a narrow range. You got to get it from somewhere, so your body robs it from your bones, and then you get avulsion fractures and complications associated with this. And then there's soft tissue problems that we see a lot in our diabetic patients. They have increased risk of plantar fibromatosis. They have an increased risk of Achilles tendonitis and tendinosis. This is well described by many authors, including leadership in this area by Bill Grant out of Connecticut, not Connecticut, Bill's from wherever he's from, Connecticut. Aquinas is very common in our diabetic patients. Achilles tendon stretching is a big part of my program in many of our diabetic patients. If you're not checking for it, you're not going to find it. Increased forefoot loading, increased pressure to the midfoot, all the problems go along with Aquinas. Sarcopenia. Many of our patients, as they get older, lose muscle mass. And as they lose muscle mass, they lose bone density associated with this. They get increased risk of muscle cramping, muscle infarction. So all of these problems I just listed for you occur with increased frequency in our diabetic patients. But if you don't look for them, you don't realize they're there. And again, they don't complain of pain as a 20-year-old would with, say, a stress fracture because of their neuropathy. Diabetes itself inherently affects bone physiology. Again, we mentioned sarcopenia that occurs as we get older and is accelerated in our diabetic patients, so they have decreased muscle strength. You have the effects of glycosylation of bone proteins, just as you do with any other structure in our diabetic patient, and that affects strength and structure of the bones. You have decreased blood flow to bones. Don't forget, bones need blood also, just like bones need nerve supply. And their effects for denervation on bone. And then we have effects on osteoblasts and osteoclasts. And in general, in the diabetic patient, you have early morbidity of mesenchymal-derived cells, less cells that are precursors for osteoblasts differentiate into osteoblasts. We have increased osteoclastic activity. We have decreased insulin signaling. And as a result of that, we have weaker bones that tend to suffer from avulsion fractures and stress fractures. So we have reduced bone strength in our diabetic patients in general, superimposed on the effects of aging. So we have the effects of aging and then the effects of the diabetes. As a result of that, most diabetic patients have a chronic low-grade state of inflammation in their bone marrow. We have measurable increased markers in inflammatory cytokines. We have increased death of mesenchymal cells that are precursors to become osteoblasts themselves, decreased selection to become osteoblasts, and of course decreased activity. So quickly, first of all, gait analysis. I don't know how many of you routinely do gait analysis in your diabetic patients. It should be done on all of your older diabetic patients. You've got to get them up, have them walk, ask them 3 big questions. Have you fallen in the last year? Are you concerned about falling? Do you have a fear of falling? Do you feel unstable when you walk? And if they answer yes to any of those questions, you've got to get that patient up. You want to walk them, and you want to consider referral for gait and balance training, or consider many of the factors that can contribute to falling in our diabetic patients. Diabetic patients are well known to have an increased rate of falling. In fact, a patient with diabetic neuropathy, and don't forget, while we typically talk about sensory neuropathy, these patients have weakness of muscles from motor neuropathy, but if you don't look for that, you're not going to find it. When's the last time you checked your Achilles and patellar reflexes in your diabetic patient, okay? And they have autonomic neuropathy with deficits in proprioception. All these things contribute to gait abnormalities. They have bad eyes. They're on medications that can cause orthostatic hypotension, drop their blood pressure. Many of the medicines we use to treat their symptomatic neuropathy, the gabapentins, the pregabalins, the duloxetines, the tricyclics, the SNRIs, I got to be careful. I write for a lot of these for symptomatic neuropathy, but they can contribute to falls, okay? So all these things contribute to an up to 15 times higher risk of falls in our diabetic patient. They walk with slower speed. They walk with a wider base of gait. They have prolonged double support time. And so a gait analysis should be an absolute part of your evaluation of every single diabetic patient, regardless of why they're there. Anything from onychomycosis to stress fracture of the calcaneus. And the easiest test to do that's validated is the get up and go test. You ask the patient to get up out of the chair, walk 10 feet, turn around, walk back to the chair and sit down, and you watch them. And you could tell all sorts of issues, if they're grabbing the wall, if they're pushing off their thighs, if they're pushing off on the podiatry chair, if they're obviously unstable, if there's ataxia, if there's a drop foot. It shouldn't take them more than 3 steps to turn around. And there are times that are available for you to go read about and learn in determining whether or not a patient is predisposed to falling. I prescribe a lot of canes. I prescribe a lot of walkers. At times it's difficult. Male patients don't want to use these things. They don't want to be seen as weak. I understand that. I understand that male ego. If you don't, I'll show you my hairspray bill. So I understand it 100%. But falling and breaking a hip and having a chance of never making it out of the hospital is also a serious issue. Now, I mentioned different types of arthritis. Disc disease, diffuse idiopathic skeletal hyperostosis, is a disorder that affects primarily the heel with posterior insertional calcification and large calcifications at the insertion of the plantar fascia. These patients also have changes in their spine. It is not ankylosing spondylitis. It is different. They do not have inflammatory markers. They don't have sacroiliitis. So this is a typical heel patient with disc disease. And how many times you've taken x-rays of a patient with these large spurs, posterior, inferior calcaneus. If you go up and order some spinal x-rays, you'll see that they may in fact have disc disease. By definition, what you have here are oh, good, it works. Okay, you have preservation of your disc spaces, okay? You don't have fusion of your posterior zygapophyseal joints. You have these anterior calcifications along the anterior longitudinal ligament of the spine for at least 3 consecutive segments, and you have preservation of the exit points for the spinal nerves. So it's not ank-spon. If you did SI joint films, they would not show sacroiliitis. It is not a nerve compression syndrome, so they typically don't complain much about back pain. So you may consider disc disease in some of your patients that have large spurs around the heel. Gout. I've screamed about this from the time I was a little teeny podiatrist, and now it's become evident to everyone else. Gout occurs with increased frequency in the diabetic patient. Diabetic patients have gouty patients have a higher incidence of diabetes. So we see patients that come in like this, that they're diabetic, and you go right away, infection. We're worried about infection, but these are patients that have gout. So the incidence of gout much higher in our diabetic patients, and in part it's because they have declining renal function, and that's of course 2/3 of uric acids excreted renally. And the fact that many of these patients have metabolic syndrome, and that also is a partner in crime with gouty arthritis. We see this atypically in our older patients, and that's one of the reasons it's missed so much. So we have these patients that come in, we glance at their history, they're CKD stage 2 or 3 or 4, and they come in with feet that look like this, and you go, well, this has got to be an infected HD over hammer toe. This was a patient with gout. And we don't think about it, and they're not complaining of pain again because of their neuropathy. Gout is different in the older patient. The gouty patient who's older doesn't usually get that acute podagra that we're taught to look for. So they don't come in with this acute, swollen, painful joint. They have a more low-grade chronic disorder, and you could say, oh, it's hallux limbus or something like that. They tend to be oligoarticular, and they tend to be having more tophaceous deposits. Here's some of my patients as an example. This is from the clinic. Diabetic patient, poor circulation. They come in with this. Oh, my God, they're infected. Gouty tophus that's ruptured. Another one, oh, they're diabetic. They got PAD. They got ulceration. There's your x-rays, and the patient had gout. And one of the difficult problems about treating older diabetic patients is drug selection. We really don't have great choices for these patients. A lot of times they're on anticoagulation therapy. They've got CHF. We don't want to raise their sugars. We don't want to worsen their renal function. So treating them sometimes is more difficult. Hydroxyapatite deposition disease. This usually is going to take a biopsy to see, but we see this as calcific tendonitis and Achilles tendinosis. So the next time you have some patients with Achilles tendons that look like this, you might consider hydroxyapatite deposition disease. This was one that had a little calcification of the bursa medial to the first metatarsal head. So you might consider that. Calcium pyrophosphate deposition disease, while it can cause pseudo-gout, many times, again, it can cause this chronic low-grade inflammatory change. This patient with extensive calcification, they could cause what looks like osteochondromatosis. And this is classic pseudo-gout. It's, it's a positively birefringent crystal. It's more rectangular in shape. It does respond to colchicine, by the way. It's one of the 4 diseases that responds to colchicine. You have gout, pseudo-gout, sarcoid, and familial Mediterranean fever. So the response to colchicine doesn't rule out pseudo-gout. Here's an example, again, a patient that had this little calcified bursa, subcutaneous cystic changes, calcification or deposition within the inferior calcaneal bursa. Chiroarthropathy, or stiffness of the joints. You always see this classic prayer sign that people talk about. This is due to buildup of advanced glycosylation end products in the forefoot, midfoot, and hindfoot. It leads to decreased range of motion of the ankle, subtalar, midfoot, and forefoot joints. The longer a patient has diabetes, the more glycosylated their joint proteins are, the more they begin to lose range of motion, and has been shown or suggested to be a contributing factor to increasing forefoot pressures and increasing liability to ulceration. And again, you could take the time to read up on treatment options for treatment of chiroarthropathy. Then you have metabolic bone diseases. Again, the diabetic patient tends to be more osteoporotic or osteomalacic. They have secondary hyperparathyroid disease. Their bones are weaker. They tend to get more fractures. So we see these in our diabetic patients, especially diabetic patients with renal failure. Those of you that do Charcot joint disease work know full well that the worst thing you see is a hindfoot Charcot in a patient that is on dialysis or has end-stage renal disease. That's just the worst combination you could get in these Charcot joints, other than having some vascular disease. And don't think you can't get a Charcot joint with PAD, because you can. So we have the effects of this declining renal function. Our patients are coming to our office, they got PAD, they got CKD, or they're end-stage renal and they're on dialysis. Well, what are you losing that affects the bones in the kidney? Well, for one thing, they're anemic. That affects your bones, and wound healing, by the way. And they have decreased vitamin D, therefore decreased calcium. So what do? Your parathyroid gets active and says, we need calcium to live. Your mitochondria need it, your muscles need it, your heart needs it, your nerves need it, everything needs calcium. You can't live without it. So you start breaking down your bones. And as I mentioned, as you remember, vitamin D is basically synthesized in the skin. It goes to the liver, becomes 25-hydroxycholecalciferol, then goes to the kidney, becomes 1,25-dihydroxycholecalciferol. And it's one of the reasons, by the way, that the International Working Group on the Diabetic Foot recommends that when you're treating Charcot joints, remember to get a vitamin D and calcium level. So we have these patients that we see in our offices, and again, they're neuropathic frequently, so they don't complain of pain. But to get all these manifestations of secondary hyperparathyroid disease. So here's some of our patients. This patient had an active Charcot, but look at the resorption of the ungual tufts. This is one manifestation. They get extensive vascular calcification. When you see calcification, and if you don't know, you should read up now. You have MAC scores that are available for classifying this calcification. Dorsalis pedis is a 1, PT is 2, first intermetatarsal arteries 3, hallux arteries are 4, and the lesser digits are 5. And MAC scores are predictors for poor outcome. When you see calcification and osteopenia like this, you think about renal disease, you think about secondary hyperparathyroid disease. The other thing you think about is autonomic neuropathy. Here's a patient that had a brown cyst, is losing all this bone in the calcaneus, osteitis fibrosa cystica. The biggest problem I see are patients like this. These are patients of mine who came in with ulcers. And for example, this patient, if I remember right, had an ulcer sub 3, and you get an x-ray, and you see they had a stress fracture of 5 and 4, but they never felt it. They never felt it because of their neuropathy. If you don't take both shoes off, and if you don't get these patients up and walking, there's a lot of pathology you're just going to miss. I ask the residents all the time. I do my little secret surveys. I say, how often do you see doctors with whom you rotate actually walk patients? Hardly ever. I do not understand how you could be a podiatrist, make decisions on surgery and various therapies, and not have a patient stand up and walk. But I've got a ton of these patients. This was a sub 3 ulcer with a stress fracture. This patient has stress fractures 2, 3, 4. This patient had ulcer sub 1, dislocated the first, has stress fractures 2 and 3. I see a lot of stress fractures of the calcaneus. And you should be x-raying these patients and feeling for this. And these are all diabetic patients who are end-stage renal disease that had this patient avulsed the insertion of the Achilles tendon. This was one that fractured and then developed an ulcer from the fracture, and complications there, stress fracture of the tibia. They get a lot of avulsion fractures, and maybe this is a triggering event for Charcot joints, and these are all stress fracture patients of mine that went on to develop Charcots. And lastly, soft tissue pathology. Don't forget, these patients have increased risk of all these problems. So in summary, there are many, many bone and joint disorders that we don't talk about enough. And they're present in our diabetic patients, but if you don't look for them, you don't see them. Start watching both feet, look for unilateral edema, get them up and walk them, read up on a lot of these things. All I could do is show you the fact that these things occur with increased frequency. Look for equinus, look for Achilles tendonitis, and get more involved in gait analysis in these patients. So, Mike, thank you for the opportunity to present.